She has some mitral annular calcification. Her mitral valve leaflets are not that long, but she does certainly have severe SAM and severe LVOT obstruction, as you can see. You can probably not see it. I'm not sure why it's not playing that nicely, but what she has is severe SAM of her anterior mitral valve leaflet that's causing a large coaptation gap. If you take a look at her aortic valve, it is fluttering, suggestive that there is severe LVOT obstruction. And so when you put color on, she has severe mitral regurgitation on top of her LVOT obstruction. This is the apical 4 chamber, normal LVEF, severely enlarged left atrium, probably as a result of severe mitral regurgitation. She has, again, this severe SAM that you can appreciate. And on color, severe mitral regurgitation. Her apical 3 chamber shows that she has actually severe mitral annular calcification that's pushing her entire mitral valve more anteriorly, probably exacerbating that LVOT obstruction. So because she was so symptomatic, we discussed septal reduction therapy with her because mavacamten at the time was new. But it was invasive, so she said, "Can we please just try mavacamten first?" Her LVOT gradient was measured at 62 millimeter mercury, which basically is above 50, and so she is a candidate for either septal reduction therapy or cardiac myosin inhibitor, and that is different from her mitral regurgitation gradient, which has a much higher velocity, as you can see here. And so she started on mavacamten, and a few months post, this is her echocardiogram. She actually developed severe LV dysfunction, and her LVEF was quoted in the mid-30s. And then she had no more mitral regurgitation, though, and no more LVOT gradient. She actually felt quite good, and she was quite disappointed that her LV her LVEF has been reduced, and unfortunately we had to stop the mavacamten at that point. But at that point, she said to herself, I didn't know how it felt to not be dyspneic, and I think I'm ready for surgery. So she actually underwent myectomy, and this is her echocardiogram post-myectomy. And you can see that her EF is actually recovered, and her mitral regurgitation was simply trace. She felt really good. And so this is a segue to our first talk. I'm just going to stop sharing here. It is my great pleasure to introduce Dr. Marc Ruel. He is a graduate of the University of Ottawa and Harvard University and an internationally recognized leader in cardiac surgery. Dr. Ruel is renowned for advancing multi-arterial, minimally invasive coronary bypass grafting onto the world stage, and his expertise in complex and preoperative cardiac surgery, including hypertrophic cardiomyopathy. He is a prolific scholar. He's authored over 500 publications, 7 books, and has delivered more than 400 talks worldwide. And his textbook, Cardiac Surgical Techniques, is published in 6 languages. He's also the surgery editor for Circulation. He's a past president of the Canadian Cardiovascular Society, and he's led major national initiatives as the past president. He was also chief of cardiac surgery for 11 years at the Ottawa Heart Institute, in which time the division saw remarkable growth in both clinical activity, research, and education. So it's my great pleasure to introduce Dr. Marc Ruel, and thank you, Marc, for accepting the invitation despite being on vacation this week. The floor is yours.
It's my pleasure. Thank you very much, Hanh, for the very. I just want to. This is not the Teams app. I'm on the web-based, unfortunately, because the app is not working and the sharing doesn't seem to be happening. So I'll try to. When I press on share, it says allow to share screen or share a window.
Marc, while you fiddle with that, shall I ask Hanh some questions to buy you some time?
Yeah.
About that first case. Is that okay?
Yeah, unfortunately, I'm not on the app, so I don't know how to do this out of the web-based.
Okay, well,
the app is not allowing me to get on, so because of the migration. Yeah.
So I guess I'll ask Hanh a few questions then. Hanh, if Marc can't go ahead, we can ask our other speaker perhaps to take over in reverse order. But so that was a nice case to set the scene. And were you surprised that this patient ended up having LV dysfunction? Was there anything about this patient that made you think that they might get LV dysfunction? And practically, how often are you seeing this with mavacamten?
That's a great question. So when we see LV dysfunction, the first thing we want to really want to make sure that it is real LV dysfunction and really compare with the prior images, because as you know, it's hard to really calculate the EF of patients with HCM on echo. And then we have to think about atrial fibrillation. Sometimes they develop atrial fibrillation. HCM is just a risk factor for atrial fibrillation. So you want to make sure that they have a fib that led to maybe a tachycardia-induced cardiomyopathy in the meantime. She didn't have atrial fibrillation. I couldn't think of any other reason why, other than the mavacamten, why she would have LV dysfunction. She's been worked up for ischemia and for other etiologies in the past. So in her case, we deemed it was due to the mavacamten.
And what dose was that, on a 5 milligram dose?
So she was on the 5, and then she dropped from 65 to 50, and then we reduced it to 2.5. And she still had some LV dysfunction. So we knew that even on the lowest dose for at least 3 months, her EF just didn't recover.
Okay. And when I was in Ottawa, we weren't routinely doing CYP metabolizer status. I don't know if that has changed, in your tenure. Are you doing a CYP, and if so, do you know what her CYP status was?
So we're not, but I'm curious to know, are you doing it, or?
We are. We've got more ready availability than we had in Canada, so we do it on everybody. We don't wait for the results before we start prescribing, so we start routinely at a dose of 5 milligrams. I won't increase the dose until I know that they're not a poor metabolizer, but we get the results back fairly quickly with Manchester. Sorry, I realized when I introduced myself, I didn't actually say where I was working or what I was doing. So perhaps I should just do that. So I'm working in Manchester now in the United Kingdom, and I lead the mavacamten service in Manchester. And we have about 150 patients on mavacamten at the moment. So we've now got a fair bit of experience with it. We're also the local or the regional genomics service, so it makes it easier to get the CYP testing done. But actually, that's relatively, for the NHS doesn't usually work very well, but the CYP testing has been well sorted out across England and Scotland. So there are several centres that will do the testing for most of the country. So yeah, I think it's fair to say across Britain, every patient is getting CYP tested. Yeah. I'm not sure it makes much difference, I'll be honest. I'm not sure it helps me very much. Very few of my patients are poor metabolizers, and the patients that do experience a drop in EF are never poor metabolizers. In fact, they're quite often rapid metabolizers, which is the opposite of what you might expect. So anyway,
that's very
Marc,
interesting.
Marc, how are you? How are things going?
Unfortunately, this is not working. Unfortunately, it's very unusual. The Teams app is not working since the migration, so I have to do this from the web browser, and it is not sharing my presentation. Must apologize. I'll try to sort it out. But
what's the file? I know I've been seeing various suggestions coming up in the chat. What's the file size, Mike?
Yeah, it's like 4 gigabytes, right? There's a search code video I want to.
I see.
Yeah,
could you? So
that, right?
We transfer will take files, I think, up to 4 gigabytes without an account. I don't know if that might be an option.
It'll be a while before we get it, though. That's the only thing. Start. I'll send it to Haley, and perhaps we can go with Dr. Maj's talk, and I'll see if I can.
Yeah, no, perfect. So I will then present the other case leading to Dr. Maj, Dr. Maj's talk. Just give me a second here.
All right, thank you. Maybe it falls well because I'll start talking about the cardiac inhibitors before surgery. So
Perfect.
maybe the talk should be first. Maybe it's the way things should be. Let me try to get.
Let me just introduce your case. Well, let me just present your case, and then I'll introduce you. That
Okay.
work? Perfect.
You want to share first?
Yes.
Okay.
Can everyone see my slide? Perfect. So this case is a segue to Dr. Maj's presentation. It's a 64-year-old man. He comes to us with progressive chest pain on exertion. Has been worked up, has had a CTA that does not show coronary disease. And here's his echocardiogram. It's working better this time. So this is the peristonal long axis. We see that it looks like there is some systolic anterior motion of the mitral valve. His septum is thick. It was measured at 18 millimeter. There's some asymmetric septal hypertrophy. His aortic valve is somewhat calcified too, and he's got some mitral annular calcification as well. So a little bit of SAM possibly, and then we're going to put some color on. There does not look to be significant mitral regurgitation on this image, and not very much flow acceleration either. In his apical 4 chamber, we see that the EF is either normal or hyperdynamic, although his apex is not contracting as well as we would like. We can't see much of the endocardium though. So we put color over the entire LV to see what is going on. And what we notice is a little bit of flow acceleration in the mid cavity. So you can see here, in systole, there's a flow convergence right at the closer to the apex. So we, with pulse Doppler, we interrogate the entire LV to see where the flow acceleration is, and it is where the convergence zone on color was. So that's where the highest velocity was. And so with CW Doppler, we can see this sort of biphasic Doppler signal, which suggests that there is blood flow in systole out of the LV, which is normal, but there's also blood flow in diastole, suggestive of an apical pouch. The gradient for this Doppler signal was measured at 30 millimeter mercury. So when we suspect that there is an apical pouch, we want to give contrast to make sure if there is an apical aneurysm, because that is clinically significant. And in this patient, there was an apical aneurysm. There was no thrombus. He also had LVOT obstruction, as we suspected with the SAM on the peristonal long axis, and his LVOT gradient was measured at 78 millimeter mercury. So this case simply begs the question, had this patient not had LVOT obstruction, what would be his options? Does mavacamten apply for patients with mid-cavity obstruction, only with LVOT obstruction? Can you tell us more about that? So I'm gonna stop sharing and just introduce you, Dr. Maj. So Dr. Maj received his Bachelor of Science in Physiotherapy from McGill University and his medical degree from the University of Montreal. He completed medical residencies in cardiology and internal medicine at McGill University, where we were co-residents. And after that, he completed an adult echocardiography fellowship at the University of Toronto. He joined the Division of Cardiology at the University of Ottawa Heart Institute in 2024. He's an echocardiographer, general cardiologist, and attends at the HCM clinic. So over to you, Dr. Maj.
Thank you for the introduction. Thank you everybody for joining. We will discuss today mostly the historical aspects of things, how things have changed over the last few years, the last half decade. There's been a lot of changes in HCM, and we will talk about cardiac myosin inhibition, how things came about, how guidelines have changed, and what is coming up in the future. I have no disclosures. So we first will talk about the historical management, and then the cardiac myosin inhibition in obstructive HCM, the trials in non-obstructive HCM, and the future directions and novel therapies, things that are coming in the future. I don't want to spend too much time on hypertrophic cardiomyopathy and the definitions, but briefly speaking, hypertrophic cardiomyopathy is characterized by left ventricular hypertrophy, and on microscopic slides, there's myocyte disarray. It's a genetic disorder affecting 1 in 500 individuals. On genetic testing, patients would be positive for pathogenic variant maybe 30 to 50% of the time. We divide HCM currently into two main subtypes, obstructive and non-obstructive. Obstructive HCM is really classically defined as the LVOT obstruction, which visually is associated with systolic anterior motion of the mitral valve, so-called SAM. And there is also the element of midcavitary or midventricular or intracavitary obstruction, MCO, MVOs, intracavitary. These obstructions are further down in the mid-septum or distal septum, usually not associated with SAM, and it is the hypertrophied septum with a hypertrophied papillary muscle or a displaced papillary muscle that may cause the obstruction in mid-cavity. And lastly, there is the non-obstructed HCM, and sometimes these mid-cavity obstructions are misclassified into this as they don't have the classical LVOT obstruction. And these are mostly the apical HCMs, Yamaguchi syndromes. The historical management, and historical is under quotation, is as the historical management goes up to 2020, so about half a decade ago. At that time, as we know, the first line for symptomatic patients with HCM was beta blockers or calcium channel blockers. And second line was medically was disopyramide. And if failure of diso or patient would not take diso, it will be surgical management or catheter interventions. Now, in the last 5 years, there's been novel treatments that have been coming up with the cardiac myosin inhibitors. Currently, we have 2 cardiac myosin inhibitors that are on the market, mavacamten and aficamten. Mavacamten was the first FDA-approved cardiac myosin inhibitors. In the gist of it, it's an allosteric inhibitor of the cardiac myosin ATPase, and it decreases the cross-linking of the myosin-actin heads, which decreases myocardial contractility and functionality and enhances a super relaxed state. The half-life of note for mavacamten is about 7 to 9 days, compared to aficamten, which also binds in the myosin head, but at the S1 catalytic domain. Of note, aficamten does have faster pharmacokinetics. There's been a bit less of LVEF reduction, and the half-life is shorter due to the faster pharmacokinetics, about 2 to 3 days, which may be a potential for improvement of safety and dosing flexibility in terms of medications. The FDA approved aficamten in 2025. The indications are obstructive HCM. Mavacamten has a classification of NYHA 2 to 3, while aficamten has only symptomatic obstructive HCM, minor detail. This is a diagram of what I've just discussed. As you can see, the binding site is similar, but not exactly the same. So let's talk about the history of obstructive HCM trials. We will go through phase 1 and phase 2 trials just to be complete. I will skip over the phase 2 trial probably quickly, just to talk about the phase 3s. Here I mentioned the 2 molecules and the date and chronological order of obstructive HCM trials. So the first phase 2 trial was Pioneer HM. It was a mavacamten trial for obstructive cardiomyopathy. It was mostly a dosing trial, 21 patients, and the main findings were that there was significant LVOT, the obstruction gradient decrease, an increase in peak VO2. There was some decrease in LVEF, and there was a signal for atrial fibrillation. But mostly mavacamten was well tolerated in most patients. Explorer-HCM, based on Pioneer, was the first phase 3 trial with the question, does mavacamten improve exercise capacity and health status in patients with obstructive HCM? It was about 250 patients, randomized 1-to-1, mavacamten versus placebo, which was patients on the current standard of therapy, beta blockers, calcium channel blockers. There was no disopyramide in this trial. The goal was to titrate the mavacamten to LVOT gradient of less than 30. The inclusion criteria were quite straightforward. Adults, the definition of HCM, 15 millimeters or 30 millimeters with family history of HCM. Patients were symptomatic, but not NYHA4, 2 to 3. And the LVOT gradient of note was 50 and above, and EF was 55 and above. These two values, you will see, will change intermittently between different trials. The capacity to perform a CPET was just to follow up the primary endpoint, which was peak O2. Primary outcome, as I just mentioned, was first and foremost a composite of 1.5 millimeter of oxygen per kilo per minute on a CPET with a peak VO2, plus an NYHA class improvement of at least 1, or the fact that they increased their VO2 max by 3. Clinically, an increase of 1 is already significant, but they were kind of going higher on the bar to make sure that this is a significant improvement. The results show that there was a 37% improvement in the mavacamten versus 17 in the placebo, which was statistically significant. Secondary outcomes, as you can see here, some of them are echocardiographic, some of them are capacity, and there are some questionnaires for symptoms overall. So LVOT gradients were dropped, peak VO2 was increased, NYHA classification was improved by 1 or more. The KCCQ score is for symptoms, and HCM SQ is angina with HCM. And as you can see, all of these were statistically positive for mavacamten. So in conclusion, mavacamten did improve exercise capacity at 30 weeks in patients with obstructive HCM. Followed up was Valor HCM in JACC 2022. Once again, obstructive cardiomyopathy with mavacamten. The question here was more, would adding the mavacamten to maximally tolerated medical therapy, would that allow severely symptomatic obstructive cardiomyopathy patients to improve so much that they no longer qualify for CRT therapy, so septal reduction therapy? So phase 3, randomized control, double-blind, placebo-controlled, about 100 patients, 1-to-1, placebo versus standard of care, mavacamten versus standard of care, which was placebo for 16 weeks. Inclusion criteria is pretty similar. However, patients were more severe in symptoms, and they were also including disopyramide patients, NYHA 3 to 4 instead of 2 to 3. If 2, then it was syncope. Syncope mostly linked with LVOT obstruction. LVF was slightly higher, LVO2 was 50, and they had to be referred for CRT in the last 12 months. So the primary outcome, the decision to proceed or just to stay eligible for SRT was 17.9% versus 76% in the standard therapy group. Very statistically significant. The secondary outcomes, similar to all other trials that we're going to be seeing, improvement in OHA, decrease in resting and Valsalva gradients, and the KCCQ scores also positive. Usually a reduction of 10 on the KCCQ is considered clinically significant. So in conclusion, mavacamten did show a reduction in eligibility for SRT at 16 weeks. Moving on, this is a new molecule. The trialists did decide to extend the therapies to see if there's going to be sustained therapeutical advantages and if there's any signs for safety. So the Explorer LTE was it was actually the MAVA-LT study, and they showed the progression over 180 weeks, which showed that there is sustained improvements in gradients in biomarkers in clinical status. There has been about 20 patients who experienced transient decrease in LVEF, less than 50, but all reversible, as both aficamten and mavacamten are reversible agents. Moving on. Valor HCM did the same thing, extended the study for 128 weeks. So it's the original Valor HCM cohort study. The patients who were on mavacamten continued mavacamten, and the patients who were on placebo were crossed over to mavacamten to continue for 112 weeks. The primary endpoint was the same as for the Valor HCM, the initial study. It was a percentage of patients meeting or proceeding to CRT, and the results, SRT, sorry, and the results were 15.7%. And as we just recall, on the initial Valor, it was about 17%. So similar findings. Here is a diagram of what we just discussed. Patients were obviously 100% eligible at baseline, and these were the results at the 128-week follow-up. NYHA classes also dropped, and there was significant improvement to NYHA 1 from an NYHA base of probably 3 to 4. Big difference. This is a diagram just to give you a perspective of what we just discussed. They're ongoing to follow up for long-term effects. Another slide to summarize the trials that I just mentioned. However, let's focus on the safety. Safety, interesting enough, I don't have p-values on this, but the initial signal in the phase 2 trial of Pioneer, where there was a signal for atrial fibrillation, we're not seeing much in some trials, maybe some in the other ones, but it looks to be a small amount. LVEF drops is expected with the way that the mechanism of the molecule, but it is low numbers. And in terms of cardiac failure, at least on Explore HCM, the placebo cohort had more cardiac failure symptoms than the mavacamten ones. Now, moving on, now we're flipping over to aficamten. So first study of obstructive HCM in aficamten was Redwood HCM. So it was a dose-finding trial, phase 2. They looked at the outcomes. As you can see, we had a decrease in gradients. We had a decrease in resting in Valsalva, increase in NYHA classes, and LVEF was a slight decrease, but did not cross into the threshold where they were worried about a drop in severe EF. There were actually 4 cohorts technically for the Redwood HCM trial. The first 2 cohorts were just a question of dosing because it was a dosing trial. So cohort 1 had lower doses, cohort 2 had higher doses. Cohort 3 was sicker patients on disopyramide, N of 13. And cohort 4 is a specific cohort. It's actually non-obstructive HCM that I will discuss separately. Sequoia was the follow-up study, phase 3 trial for aficamten. And the question was, does aficamten improve exercise capacity and health status in patients with obstructive HCM? It was a study of about 300 patients, 1-to-1, aficamten versus standard of therapy, placebo, for 24 weeks with a 4-week washout period. The inclusion criteria is similar, but slightly different, resting LVOT of 30 and a Valsalva more than 50, and the LVF of 60. The primary endpoint was to assess peak VO2. Peak VO2 increased by 1.8 versus 0 in the placebo trial, placebo group. And the secondary endpoints, once again, similar standard endpoints that we've been looking at: KCCQ, NYHA, Valsalva, LVOT, and what is the Valsalva gradient? When does it become non-significant? And the Valsalva gradient became non-significant in about 49% of patients versus 3.6 in the placebo group. So quite positive signal for obstructive HCM in both molecules. Sequoia HCM did do some subgroup analysis. One was 50 patients in this were picked to do a CMR substudy. The CMR substudy of note, we saw that there was decrease in LABI size, so left atrium was smaller. We saw a lowering of T1 signal, signifying that there might be less fibrosis ongoing. So some positive findings on the CMR side. They also did not a sub-study, but analysis of the patient by echo. So the whole cohort was tested, and we saw quite positive findings of decreased LVOT gradients, increased volumes of the ventricle, decreased wall thickness, improved diastolic findings such as decrease in LAVI, increase in E primes, and E over E primes were decreased for diastolic dysfunction. out of what was interesting is that they did try to match the symptoms and the findings on exercise capacity with the findings on echo. And they found that the peak VO2 and the reduction of NT-proBNP was improved with lateral E prime improvements and the E over E prime. So diastolic dysfunction was showing to have some biochemical and peak VO2 changes, while the symptoms themselves on the KCCQ was associated more with LVOT gradients, which would be the obstructive part of the disease. Something to note. Just like the mavacamten group, the aficamten group decided to see what the long-term effects are of the aficamten, and they have a study called FOREST-HM, which they took both Redwood cohort and Sequoia cohort and are following them for 5 years. So far, there was only a 48-week analysis published in 2025 in JACC, with only 46 of these patients. Due to patients enrolling into the study, they only had 46 at this time. The findings are pretty good. Seems like everything has been sustained. The gradients have been sustainably decreased. The NT-proBNP stays low. The LVEF stays about the same and above the cutoff of 50. And symptoms as well maintain themselves at better functional capacity. Based on all of these trials and phase 3 trials, in 2024, there was an update to the AHA guidelines for HCM. As you can see, myosin inhibitors have become class 1 after failure of first-line therapy with beta blockers and calcium channel blockers. And if EF was dropping, obviously, if you are on a cardiac myosin inhibitor, one option is to stop the mavacamten and see for the rebound for the EF to come back to normal. Therefore, the next logical step was to perform a trial to see if cardiac myosin inhibitors could be used as monotherapy. So Maple HCM was developed. It was an obstructive HCM study with aficamten, and it was aficamten monotherapy versus metoprolol monotherapy for 24 weeks. The inclusion criteria were patients with NITRate 2 to 3, and the gradients and the EF was similar to the previous studies. As you can see, these are the secondary endpoints. There was improvement in pretty much every single endpoint that they were looking for. The primary endpoint, though, was improvement in peak VO2. So with aficamten, there was an improvement in peak VO2 of 1.1, and with initiation of metoprolol, they had a decrease of 1.2, the total difference of about 2. The secondary endpoint is just like on the previous slide. The NYHA, the KCCQ, the NT-proBNP, the Valsalva gradient, the LAVI decrease. The only one that did not reach statistical significance was the LV mass, although the study was a short study. So in conclusion, aficamten in obstructive HCM looks superior to metoprolol in improving peak VO2 as primary. And that is it for obstructive at this time in the big trials. So moving on to the non-obstructive HCM trials. As you can see, there's quite a bit less of them. So starting off with Maverick HCM, JACC 2020. This was once again a phase 2 trial for dosing. They included pretty standard patients for HCM diagnoses, symptomatic, EF of more than 55. NT-proBNP had to be positive, as this is a non-obstructive trial. And if they were symptomatic with NYHA, and NT-proBNP would suggest that there's diastolic dysfunction or there is some cardiac component to it. The exclusion criteria were that there was no LVOT or intracavitary gradient of 30 millimeters of mercury. And here is where this mid-cavitary obstruction element needs to be looked into details. So MVOs were excluded explicitly in Maverick. So primary analysis and safety, only 5 patients had a decrease of LVF to 45 in the study. It was reversible. And secondary endpoints or exploratory endpoints were looking to have some signs of at least biochemical improvement. And when they analyze a subset of patients that appear to be a bit more sick, a bit more having diastolic dysfunction with E over E primes of 14 and above, or troponins above the 99th percentile, they saw that there was an improvement in peak VO2 and NYHA class, or a significant peak VO2 of 3 in 33% of patients. As you can recall, these are the same primary endpoints as in the initial studies in mavacamten for obstruction. Redwood HCM cohort 4, which I mentioned earlier, was a fourth cohort of aficamten patients with non-obstructive HCM. In this case, MVOs were not excluded. It was a very small study of 41 patients, and the MVOs were only 7. The inclusion criteria is similar, no gradient, EF above 60, and NT-proBNPs were positive. The primary endpoint was safety. Nobody dropped their EF less than 50. And the secondary endpoints, very small study. There was no placebo. So it was just percentages. There was improvement in NYHA, KCCQ. EF, there was a drop of 5%, but everybody remained above the threshold of 50. NT-proBNP and troponins were also decreasing. This time around, the subgroup analysis, similar to what Maverick had, did not show any improvement in patients who appear to be sicker with more diastolic dysfunction. And they did an analysis for the presence of MVO, and there was no improvement, but it was a tiny number. And if you do look into the supplements, MVO was not clearly defined. It seems to be that they also took LVOTs that fell between 30 and 50. So once again, MVOs are a very murky subcategory of HCM. Finally, Odyssey HCM is the first phase 3 trial for non-obstructive HCM, this time around with mavacamten. So about 600 patients, 1-to-1 division for 48 weeks. Inclusion criteria is similar to the previous, and they mentioned explicitly that they can have mid-ventricular obstruction, although no details are published further for that. The primary endpoint was peak VO2 and KCCQ score improvements. Unfortunately, with this study, there was no statistically significant improvement. Secondary endpoints, also no changes in biochemical values on CPETs, NYHA, and angina scores. So in conclusion, Odyssey HCM in non-obstructive HCM, mavacamten did not result in improved exercise capacity. Now, this might have been a negative study. However, there is plausibility to the mechanism. So there are published analyses of echo findings for the Odyssey cohort. And we do find that with the cohort, there was findings of improved structural changes. The alveolar wall thickness is decreased, the mass is decreased, the diastolic function values appear better, the LA function or the LAVI is decreased, and the strain function of LA also appears to be improved. So the question is, were the studies too short? We're seeing some physical changes. Does it take more time to see clinical improvements? In the long term, will that modulate the chances of having heart failure? To be seen. So here we are. We've started, and at the beginning of this decade with just beta blockers, calcium channel blockers, disopyramide, and then surgical approaches. In the last 5 years, we clearly see that the cardiac inhibitors have been very effective for obstructive HCM. For non-obstructive HCM, it will be seen in the future. And there are already thoughts and processes for future novel therapies, such as metabolic modulators and gene therapy. Talking briefly about what's in the pipelines, aficamten, they also have to have their phase 3 non-obstructive HCM trial. That is coming with Acacia. Thoughts about diastolic dysfunction of non-obstructive HCM and obstructive, sotagliflozin, which is an SGLT2 1 and 2 inhibitor combined. So we have Sotacross and Sonata HCM in the pipelines. The novel metabolic modulator, one example is ninarafextat, if I pronounce it properly. This molecule promotes the change of using glucose as a primary metabolite versus fatty acids. There has been a phase 2 trial that has been completed and published in JACC, Improve HCM, and now there's a phase 3 trial, Fortitude HCM, that's ongoing. For gene therapy, there is already signs that there is something down the pipelines. For example, MyPeak-1, which is a specifically for patients with MYBC3 mutations of truncation. There has been development of gene therapy with a first publishing last year of 6 patients who have been given this medication trial, the retrovirus, and there has been signs that NT-proBNP troponins LV thickness has been decreasing. So good signs, but they're planning to include about 30 patients, and we'll see in the future what happens. So in conclusion, it appears that cardiac myocyte inhibitions are here to stay, and they're quite clear that obstructive HCM is a subcategory of HCM that does respond very well to cardiac myosin inhibitors. The question is, long-term, how long can we be on this? Is the safety profile good for decades and not just 5 years? Ongoing trials, maybe longer trials if the funding can be found to continue that. And is it just as durable as septal reduction therapy? Disease modification, symptom relief. We're changing symptoms, we're changing gradients, but will that be long-term decreasing heart failure dysfunction? We know it's reversible. Do you stop it? Do you come back? Or do you actually modify the heart failure component 10 years down the line? And then what do we do with non-obstructive HCM? And where does MVO fall into? Should we have a specific trial with MVOs that is defined? Mayo Clinic has a definition of MVO from 2011. Should we have a specific cohort? Is 10% of the obstructives that are MVOs? Currently, are they included somewhat in the obstructive trials and we just didn't pick them out? It's hard to say. CMI versus traditional therapies, should we, like Maple HCM, should we be doing this upfront before beta blockers and before calcium channel blockers? We see that the people have decreased peak VO2s. Does that change their clinical symptoms? To be looked into. Cost effectiveness. The medications are new, they're expensive. This is a long-term therapy. We are doing long-term trials to see how it goes down 5 years down the line. So we need to figure out how that goes in terms of cost effectiveness versus surgical approaches, which are more likely long-term curable. Sometimes it grows back. And lastly, the next steps. What else can we do? I presented 2 possibilities. What else could we find to be determined? All right. Thank you very much.
Thanks very much, Dr. Maj. That was a fantastic talk, an awful lot of data to get through. You did a great job summarizing all of that. I've got so many questions for you or for Hanh or for the audience. Before I ask though, Hanh, how much time do we have left in this session?
We have 45 minutes left.
Okay. And do we know what the situation is with Marc at the moment?
His slides are working, so I will be presenting them. Marc, is half an hour good for you?
Yes, it is.
Okay,
Perfect.
great. Well, perhaps just before we get on that, I mean, so many questions. Some are very sort of just straightforward clinical questions, and some are a little bit more mechanistic. So I'm always fascinated to see the reduction in LVH, and I guess like many people, I had assumed it was due to the relief of outflow tract obstruction. The non-obstructive trials, however, also show a reduction in LVH, which is interesting and curious, and perhaps suggests there's something going on at a sarcomeric level that is different to simply relief of obstruction. Or it may just mean that the non-obstructive population are actually poorly characterized. So the trouble I have with the non-obstructive trials is that they're all entered on the basis of resting echo with Valsalva. None of them are on the basis of exercise. And we know that a third of so-called non-obstructives will be obstructive when exercised. And I wonder whether, in some of these, in Odyssey, for example, which obviously was a big disappointment to Bristol Myers Squibb, I just wonder how many of those patients might actually have had obstruction if you exercise them. And if you had looked at the results in that subpopulation, would we have seen a signal of benefit? I don't know what you both think about that.
Very good points. Thoughts that I had myself. Exactly on point. How does the thickness decrease over time with non-obstruction? Non-obstruction, we actually don't usually measure or try to measure if there's anything in the mid cavity. Most of the time, we're trying to avoid the mid cavity and try to go into the LVOT. So, are the non-obstructives, the apicals that we call non-obstructive, are they having an obstruction there, and is that creating the same obstruction flow, and the apex has no outflow, and then we get the aneurysms? I mean, that's my most plausible mechanism for apicals for getting their aneurysm, is that their heart is squeezing against a logged volume of blood because it can't get through, and we just don't calculate that gradient. So it's very very peculiar.
We've got a question from Catherine in the audience who wants to know whether we think these drugs reduce the risk of ICD and arrhythmia, and that's a really interesting question in terms of what gradient do you now put into the HCM risk calculator? Do you put in the pre-mavacamten gradient or the post-mavacamten gradient?
Great question. Same thing. I've been here on staff for a year and a half. Great question. That's exactly what I was thinking. With this modulation and it's sustained, do you change the risk, the LVOT obstruction? You assume that it will cause fibrosis, especially in the apicals, that maybe it's related. So if we're seeing that the T1 signals on MRIs are dropping, that could be a sign that there will be no LG deposits in the future. I mean, we're trying to see all of these LVOTs, and our risk stratification is to find secondary steps in the cascade of having scarring, which then causes the VTs. So very good questions. I have them myself. Currently, I err on the side of caution, and I use the highest gradient I can find, and put in a calculator.
I think that's still common practice. Actually, is what we do as well in the UK. This debate comes up. There's no doubt that theoretically reduction in the gradient should reduce the risk, because we know that if you have a good myectomy with a good reduction in gradient, your age-related mortality is the same as the general population. So, and also that the gradient is a major part of the risk equation. So in theory, it ought to reduce the risk, but I think most of us are treading carefully and still putting the pre-mavacamten pre-therapy gradient in. And then a question for Hanh. What do you do when you get a patient coming in who you think should have mavacamten and they're already on disopyramide? What's your approach to that?
I tend to, first of all, we want to know why they're on disopyramide. Is it simply for LVOT obstruction, or is it also for atrial fibrillation? So in the Valor, there were some patients on disopyramide and mavacamten, and having prescribed mavacamten for some years now, it doesn't really change the QTC that much or at all, in my opinion. So, I mean, I don't have many. I maybe have one that's on mavacamten and disopyramide. I've kept on disopyramide because it was also for atrial fibrillation. But if not, I would tend to just stop the disopyramide.
Okay, so that's, again, my practice has changed. So I started by stopping disopyramide in everybody when I was in Canada, because I was worried about, too much negative inotropy or QTC prolongation. And then I got into trouble actually with a couple of my patients who were very disopyramide dependent and who had a period of being much worse in the first month or so on mavacamten, but without disopyramide. And then as I went back through the data, as you presented, Jakub, with the Valor trial showing that a number of patients were on both drugs quite safely, I changed my opinion. So now I routinely keep people on disopyramide until they've had 3 or 4 months of mavacamten, had a good gradient reduction, and then I usually try and get them off disopyramide. And we have the same problems in the UK that you do in Canada, that it's intermittently available, and so it can be a problem. With regards to the Maple trial, I always felt that was a bit of a cheat, randomizing patients to a beta blocker or mavacamten, because there was never any doubt which one was going to win. The trial that I wanted to see really was mavacamten versus disopyramide, and the trial that I really want to see is mavacamten versus aficamten, and of course neither of those two trials are ever going to be done, but there we are.
Yeah, I think though Maple actually is clinically very important, even if it is sort of, we kind of know the conclusion, and it's very clinically important because there's a lot of people who probably have some side effect of their beta blocker. So now the question is, once you start mavacamten and they start feeling better, do you stop the beta blocker? Or, do you know what I mean?
Yeah.
Go ahead, Dr. Maj.
Yeah, no, I think that's fair. I mean, I stop it if they have no other indication for the beta blocker. So if they don't have hypertension, if they don't have atrial fibrillation, if they don't have angina or something else, then I'll stop it. I must admit, I'm much more aggressive now than I used to be about treating hypertension. I know we're all cardiologists. We should all be very aggressive about treating hypertension. But I think as HCM cardiologists, we're guilty of trying to treat a gradient when the problem is breathlessness. And so I actually think we should be treating the triple threat of hypertension, obesity, and outflow tract obstruction. And I think we're very good at doing one of those things. And certainly in the UK, we're not very good at doing the other two. So yeah, that's my thought on that.
Yeah, I was about to say that for the MAPLE HCM, it might have not been ethically feasible, but to have a 1-to-1-to-1 placebo, metoprolol, and the cardiac inhibitor, just to see that it's even if somebody wasn't started anything, obviously you'll get a benefit, because now with the metoprolol you had a decrease in VO2 max, so they could feel worse, but then just having a placebo arm where nothing is done.
Yeah.
And go from there. But standard practice right now is to have the beta blocker on. So I don't know
Sure.
if that would have passed ethics.
Yeah. I have two maybe comments before Dr. Ruel's talk. Number one, in pediatrics, I think that there is a good enough data, safety data for mavacamten now that they're doing a trial in, I believe it's 13 to 17 or 12 to 17-year-olds.
Yeah.
So that's up and coming. And the other, what was my other point? My other point was about the Odyssey trial. I think we chatted a little bit about it, Dr. Maj, that the safety endpoint of 60% EF, right? So their endpoint was basically you give the dose, but you want to keep the patient above an EF of 60%, which a lot of the cases, some of my patients, they go from an EF of 65, 70, and they come down to 50, 52, and I keep them there because they feel so good. So I wonder if the protocol was not aggressive enough.
Yeah, when you look at the protocol, the safety, the beginning, the initiation portion seems to be very high. They were looking at keeping the EFs above 60 and dropping down the medications. No 55s, you would have to back down at the initiation phase. Afterwards, they did allow it, but maybe people weren't maximally dosed as well.
Can I ask, have you seen, so there are reports of electrical remodeling with T-waves flipping upright. And in fact, this week, I think there was a report of someone apparently regressing from left bundle branch block into normal QRS duration on mavacamten. I have to say electrical things haven't been something I've particularly noticed. I wondered if either of you had seen that.
So I have noticed some changes, but dramatic changes like that, I will pay. To be honest, I don't always pay attention, but if you look at sort of the longitudinal over years, I have seen some changes.
Last question before we move on to Marc then. What are you saying? How are you advising your 32-year-old female who hasn't completed her family yet?
Yeah, that's a great question. I had it wasn't my patient, it was a patient of another colleague, but exactly that same situation where you can't give it because there's no data on pregnancy, but the patient is symptomatic, has a gradient of 90. What do you do, right? And they're planning to get pregnant. I mean, I would kind of really be tempted to keep them on it. But again, I, thank God, have not encountered such a situation yet.
I think Dr. Ruel is going to tell us what we should do. So with that, perhaps with that, Marc, we'll hand the floor over to you. Thanks.
If you stop sharing, Dr. Maj, I'm going to be able to share Dr. Ruel's slides.
Thank you, Andrew. Thanks, Hanh. Thank you all for being here. And Dr. Maj, that was a great talk, actually. And I think you're right. You know, the order of presenting the trials and looking at the medical therapy available prior to talking about septal reduction surgery makes a lot of sense. So I'll tell you a little bit about septal reduction surgery. So I'm not going to quote a lot of articles. It's more going to be along the lines of a crafty presentation, if you will. So next slide. I don't have any disclosures pertaining to this. Next slide. So the title that was assigned was the septal myectomy in the era of myosin inhibitors. So next slide. Essentially, I think all of you have seen septal reduction surgery being performed. Essentially, we call it myectomy, we call it extended myectomies, we call it extended myectomies and mitral valve reconfiguration, which is what I do. And we'll talk a little bit about that. But essentially, there are two approaches in the world of surgeons, if you will. Not a lot of centers do this well, and I would say very few do it well. And the two key approaches is either like what you would say. Again, I apologize for showing something that's led by Americans, but it is where the volume of referrals is mostly seen, right? As you know, in America, there's a kind of a quaternary referral type of pattern. We have a little bit of that in Toronto and Ottawa as well. We receive patients from all around the country for a septal reduction surgery. But certainly when you magnify this to the population of the US, you end up with very large institutions. And the two large ones are the Mayo Clinic and the Cleveland Clinic. And the two approaches are very different. So I know Hartzell quite well. He's now retired. And I know Nick Spadiera quite well as well. And they both have a different approach. And their volume is you know, almost one order of magnitude higher than large centers like Toronto and Ottawa would have with regards to performing these surgeries. So Dr. Schaff at Mayo, his approach is that it's always and only the septum. And in many cases, he's not wrong in saying that. It leads to a fairly simple surgery. And the results are well known. I think you've all seen the long-term survival free of recurrent disease from the Mayo Clinic, which have been essentially like seminal papers on longitudinal follow-up of this surgery. Cleveland has a different approach where Nick Spadiera believes, and his colleagues believe, that it's much more than the septum. It's kind of a distortion of the heart. And as a result of that, there are more surgical candidates, including patients where the septal hypertrophy is not very pronounced. And but the surgery is more crafty, if you will, and the results, I would argue, are less standardized. Although we know that Nick's results are quite good, it is still something that, you know, everyone does something slightly different in every patient. Next slide, please. So recently, Andrew and Rafik Tadros co-chaired this CPU from the Canadian Cardiovascular Society. The CPU is a new form of guideline, which you may have heard of. When I had the privilege of being CCS president, we started this kind of new formula, if you will, this new format, which is basically straight to the point type of short type of guidelines without grading of recommendations. So this is a really useful practice update, if you will. I would recommend to you to consult this. There's a small piece on surgery, probably smaller than what it should be. A wink to Andrew here, because surgery is an important treatment. It is the only definitive treatment. And again, the question was raised earlier, like, yeah, you're going to put a 30-year-old woman who still has a potential to bear children on mavacamten forever, or you're going to put an 18-year-old on mavacamten, or a young patient who's going to be on myosin inhibitors therapies for basically decades going forward. And we really don't have that data, as Dr. Maj clearly and very eloquently presented to us. So next slide, please. So around surgeries, around surgery for this, I'll give you a few pearls about it, which I think most of you can relate to. This is an operation which at first glance to surgeons does not appear to be too difficult, because you can actually go and take a piece of septum and really not make a big difference and not hurt the patient. It's one of these surgeries where In contrast to bypass surgery or valve surgery, where you leave, incomplete myocardial perfusion or valvular function behind, you can do this and not really hurt the patient. The patient is going through a period where afterload is relatively low. They're getting a general anesthetic. You can make things look okay, but only to realize later that the patient's not improved. And I think all surgeons who have learned this procedure, I've had a few patients who have experienced this, and you learn from the hard way, from seeing patients not being improved after surgery. And I think every single one of us who do a lot of those surgeries have encountered those patients. And I think you've seen them as well as a referring cardiologist. So next bullet, please. So it's a complex surgery, especially with regards to getting good results and helping treat complex patients. And many patients, I would say, are. And as you scratch the surface, it's a little bit like mitral valve surgery, where when you start, you only address P2 prolapse, only to realize later that it's probably less than 50% of patients. Even patients who are labeled as P2 prolapse often have some anterior or P1 or P3 pathology, etc. So the same thing, I think, holds true of HCM. As I said earlier, it's often a distortion of the heart. Many patients will have great gradients, but it may come from SAM more than from the septum itself, and it may have a thin septum. And I think as you get your knowledge and experience and surgical results growing, you get many, many more of those patients who otherwise would not have seen a surgeon. And I think the key of the surgery is really to focus on long-term effectiveness. And to do this, we have developed ways to hypersimulate or hyperstimulate in the OR as well. I'll tell you a little bit about that. When the surgery is done right, it is, in my opinion, one of the greatest successes of surgery, and also remarkably, one of the most immediate. It's really the surgery that patients come to me from all over the country. We operate on them. It's really a team effort. We usually do a multidisciplinary team before with the referring cardiologist, Hanh or Andrew previously, as our local regional expert of this pathology, and also the cardiac anesthesiologist. And I'll tell you why. Referring colleagues, I think many of you at first are somewhat skeptical of the results of this surgery, but with time, with seeing patients do well, especially complex patients with SAM, thin septums, become convinced. And the next level is precisely that, patients who have thin septas and mitral regurgitation with or without a thickness of the LVOT. Next, please. So recently we published this paper. It was a collaborative effort where we looked at about 65 patients, most of whom did not have marked septal hypertrophy, which we define as 15 millimeters or less. And next slide, please. And essentially, just to highlight the complexity of some of those patients typically would get the usual suspects with regards to pre-op testing, echo, CMR or MRI, CT, and transesophageal echo. And then next, in the OR, we really like to understand the disease a lot better. So although we meet typically the night before the surgeries as a group, and Hanh comes to these meetings, and many referring cardiologists from across the country will try to invite as well to be there and talk to us about their patients. In the OR, we use isoprel at escalating doses, typically starting at 2 micrograms per minute and then going up to 4, 6, and very rarely 8 micrograms per minute. And we see very, very interesting responses to that. Typically, when a patient's under general anesthesia, you have fairly low gradients. So and one thing that's of note is that when you're talking HCM, you're talking about peak gradients. It's not like valvular disease where it's mostly mean gradient. So we look at peak gradients, we look at dagger-shaped M-mode images, if you will. When I operate, I feel for a thrill in the ascending aorta, which, by the way, is often not large in these patients. They often have kind of restricted cardiac output for a long time, and it's rare that you have a large ascending aorta and aortic root. But feeling a thrill, I find usually starts around 25, 30 millimeters of mercury peak. And next, please. So we use isoprel in the OR. We start at 2, maybe we go to 4, and typically we'll have someone who at rest under general anesthesia will have a peak rate in say in the 20s, easily go up to 100, 150, sometimes 200 of peak gradients, and exaggerating, if you will, the SAM. And once we find the dose that has really caused those very unfavorable conditions, we keep that dose in mind, and then we use it again after the repair, once we come off pump, to really test the repair that we've done. So to hyper simulate, if you will, what the patient will be experiencing over long term. Anyways, back to our paper, which was a collaborative effort. You can see here that the mean gradients actually in patients with thin septums was as high. We're talking about peak gradients here, or the average peak gradients, should I say, perhaps more clearly, of patients with either a thick septum or a thin septum less than 15 was essentially comparable. And the response post-op was comparable again. You can see in the right-hand corner that figure, 25.7. I usually in the OR will accept on isoprel stimulation, depending on the age of the patient or so, mid-20s or so. And that usually correlates well with a patient doing extremely well from a symptomatic point of view for a long time. Next slide, please. So you can move next slide. I think it's the same again. And, you know, those patients, whether they had a thin or thickened septum before, did quite well from an NYHA point of view, basically with only 5 patients left in NYHA 3 and no patient less in NYHA 4, and most patients, the vast majority, 70% being in NYHA class 1. Next, please. As you know, the long-term outcomes are available from this large consortium in the world that is called the SHARE registry, basically consisting of European countries that have put their data together. And next slide. This was published recently in Circulation. It actually showed an 83% survival with no events which were related as either HCM related death, heart failure itself, or ventricular arrhythmias, malignant ventricular arrhythmias after septal reduction therapy. So fairly good results in that cohort, kind of middle-aged cohort, if you will, and showing the durability of surgical repair. Next slide. So in our own series, that series of 65 patients over the last 5 years, we had very comparable results, if anything favorable as well. But again, from one cohort to another, as you well know, one cannot translate results, but certainly showing that we're at least at standard, if not above it. Next. So let me tell you a little bit, we'll be a tiny bit crafty because you probably don't get the opportunity to see how that surgery is done very often. So I thought I would show you a video as to how the surgery is performed. And the surgery, you know, go back one slide, please. The surgery is really more than a myectomy itself. Again, you know, surgeons do myectomies all the time. They do what we call those moral myectomies. They take a slice of septum, and it's really much more than that. I think you can do that while you're doing an AVR or a CABG and not hurt the patient. But in reality, and as a young surgeon, I've been doing the same as well, and you probably don't change outcomes in any tangible way for the patient. So really, if you want to start tackling these conditions and have very, very robust long-term outcomes and symptom improvement and decreased gradients over time, and then the next level being addressing patients who have like almost pure SAM or thin septums, you really have to add more than just the myectomy, in my opinion. So the 4 parts of the surgery is really the myectomy itself, going as apical as you can, at least at the level of the takeoff of the papillary muscles. Then search for accessory papillary muscles. Those are not always present. I would say they're present maybe in about a third of patients, but it's very important to do that. One other aspect is that there's often fibrosis around the anterolateral papillary muscle, and there's a lot of dissection and freeing up of this anterior papillary muscle that can be done in order to mobilize it and move the mitral valve apparatus a little bit more posteriorly. Some of these patients also, whether it's primary or secondary, I don't know. It could be as a result of the destruction in the SAM. But some of these patients, regardless, have fibrotic secondary cords. And I look for those and I cut them. And typically, at a given operation, I'll cut between 2 to 6 cords as well. You have to make absolutely certain that you're not cutting primary mitral cords because of the obvious implications that that would have. And lastly, one last step that we do is to open the anterior angle of the mitral valve by immediately translocating the anterolateral papillary muscle. We use a stitch that is made out of a Teflon pledget to really bring the two soft structures together and displace the anterolateral papillary muscle towards the posteromedial muscle and really open that anterior angle. So in patients where really you cannot do a lot on, I don't know if everyone's muted. I just hear a little bit of background noise. Maybe you can mute your phone, your microphone for a second. Thank you very much. So by doing that, one thing that this achieves is really opening up this angle of a restriction at the level of the anterior leaflet and the LVOT, therefore diminishing SAM quite significantly. So next slide, please. So this, I think, Hanh will play on its own. So I presented this recently at a European meeting, not last fall, but the fall prior. So I decrease the quality of this, but the surgical exposure is the usual one. What we're putting here is a vent. We're cross-clamping the ascending aorta. The feet of the patient are towards the right side, and the head is towards the left. So I like to open the aorta like this, a little bit like an aortic valve, by being careful not to damage the aortic valve whatsoever. So you can see here, the aorta is often quite small in these patients because they haven't. I don't think it has grown to the same level as normally it would have. So I like to give myself a little bit of exposure here. So just keeping the aortotomy open a little bit. And I hope you colleagues are not gross by this, but you can see here how retracting basically the aortic root and preserving the aortic valve is obviously of utmost importance. So I like to put just a retraction stitch just at the level of the commissure without touching the valve itself in order to, and then keeping the aortic valve open, which is what you see here. So in this patient's case, there's a little bit of a nodule of Arenti on the aortic valve, but the valve is fine, doesn't need anything. So we'll start with the first step, basically keeping the valve open, performing a septal myectomy. So I'm not sure why it's not playing, Hanh. Okay, all right. So go with a blade here and start about 1 centimeter below the valve. And you can see here the visualization. The site where I like to start medially is kind of under the right coronary artery. I don't want to go much more medial than that because that's where you start getting into the bundle of his. There's a bit of a crafty aspect to it. This is the area where the TEE long axis will show you the most. So if you spend a lot of time there, you're at risk of causing complete heart block for the patient, but you will have the best TE images because that's where the long axis is mostly reflected on the TE images. So TE is not perfect itself. You know, the long axis is kind of a bidimensional and not tridimensional. And there's a lot that you can do that's not directly seen on long axis. Also with TE, initially when you cause this, as you can see, I'm cutting a lot through the endocardium. So there's literally an intramyocardial hemorrhage that takes place as a result of losing the endocardial layer. So there's a little bit of edema initially, which can affect either heart rhythm or can affect also the appearance early on until this edema then resolves and there's kind of this neoendocardium that comes on there. But we really progress on this. You're about halfway through the video. And we really craft this large slice of myocardium. And I try to aim for several grams of myocardium, ideally, depending on the amount of thickening that there is, but aiming for 5 to 10 grams of myocardium. And we weigh it and we take it out. So the specimen's about to come out now. And we basically dive deeper and deeper as we develop that specimen, which you can see here. So visualization can be quite difficult. There's a number of tricks in order to do that, like pressing on the right ventricular outflow tract and kind of, bringing the heart into view. So it's something I do a lot of minimal invasive cardiac surgery, but it's something that I prefer to do through a sternotomy. I'll tell you, I think doing it through a right small thoracotomy would be feasible, but it may not be as good in everybody. And I think here, you don't want to come twice. You just want to give the patient a great result. And you can see the slice has been taken out here. And we'll take a little bit more as well. We start with the first specimen and carry on and take more of this. So again, being careful here, because this is the area where the bundle of his and the membrane septum and the conduction system is, just under the kind of a right to left commissure. So you want to take some there, but not too much. My goal, I often say in the OR, is to create, I know it sounds awful, but to create a left bundle branch block, but no more than that. And ideally, no less than that as well. So I'm usually quite happy when we come off bump and we have a left bundle, but we don't have complete heart block. Now, many patients come in with say a first degree AV block, and obviously that doesn't help when you have this. So there is now putting your finger and thumb into the LVOT allows you also to feel the residual thickness. One of the problems with this is that you're doing it with an arrested heart, so you don't have TE guidance as you go. You can only do it and then carry on. So now looking at the mitral valve intervention. So what you're seeing here is a secondary cord here, which is slightly fibrotic. And so I'm going to cut this cord there. Apologize for the resolution. I had to make it a little bit less, so it would be no longer 4 gigabytes, but get the idea here. This is not a primary cord, and this cord is holding the anterolateral leaflet back. Now, I'm not showing you the dissection of the anterolateral papillary muscle, but what you're seeing here is putting the anterolateral papillary muscle against the posterior medial by way of a suture, which I'm basically tying now. Again, it's and you can see how the two are hugging together now with a Teflon pledget suture, basically opening the anterior angle very well so that any form of SAM would hopefully be improved. That's not always the case. Sometimes we come off bump and we realize that the mitral valve is leaking more or the SAM is no better, and we take off that suture. It's easy to get off. And at the end, essentially just closing the aorta, making sure the aortic valve is still competent and we haven't caused any damage there. So next slide, Hanh, please. So the aortas are often small. Use a thumb and finger index to feeling like the residual thickness. As I said, you seek often to ideally cause a left bundle branch block. I mentioned what the TE long axis shows is kind of under the right to non-coronary commissure. There's myocardial edema. And once we come off pump, we test with isoproterenol again at the same dose that we had awful gradients prior. And we hope that those gradients do not go above 26 millimeters of mercury peak. So based on Han's recommendation, I now chart those hemodynamic criteria before and after isoprel, pre and post repair and cardiopulmonary bypass, and chart those in the OR now. Next slide, please. So where do we go from there? What's the next horizon? And Dr. Maj took a look at this earlier. There's some non-obstructive HCM. Yeah, next slide, please. That's perfect. As you may have heard, there's now the myectomy that's been developed in China. Now, this is making a lot of noise in the field. It's basically being put through a 26 French apical incision, and it's done off bump and basically in real time. And essentially this myectomy, if you will, takes slides of the septum successively. You can take up to 15, 20 slides if you need to. And then you assess the TE as you do this because you're off pump, which makes for a really, really reliable type of assessment, if you will. And not only is this good for kind of LVOT obstruction, but it's also good for mid-cavitary and more distal obstruction. So I think the future will involve some of this. I think surgery will continue to be very, very significant. It's a little bit like everything, right? Myosin inhibitors have a great press right now, but a little bit like GLP-1s, you know, where we're starting to find that GLP-1s lead to this and that and fractures and muscle mass loss, and they're not perfect. Like no medication that anyone takes for 20, 30 years is perfect. The one exception perhaps being statins, which are probably the safest medication ever invented, but I'm digressing. Next slide, please. So there's been a number of these papers now being published, including in the circulation family of journals and JACC for the initial, and now with a recent series looking at mid and distal cavitary obstruction. Showing here by the zone 1, 2, and 3 assessments and interventions, again, performed off pump. There's a few problems with this. It's obviously it's a Chinese series. There are some North American authors as well. But that being said, you know, the bioptome or the myoptome is not commercially available in the Western world. So the jury's still out on whether this is going to be prime time and replace a very validated operation, as I showed you earlier. Next slide, please. So I'd like to conclude saying that septal myectomy provides safe and excellent relief from LVOT obstruction. In patients with mild septal thickening but symptomatic obstruction, understanding the mechanism and instruction and the role of the mitral valve is paramount. Surgery can still be offered to those patients with great success, including from your regional series, which was recently published. And the specific echo predictors of success in ACM patients with mild septal hypertrophy still need to be validated in larger cohorts. Like, even though we have, there's now 2 or 3 series that have looked at thin septas, if you will, but there's still not common ground as to exactly what needs to be done. You know, what I indicated to you using, say, 26 as a peak gradient that's acceptable post-op is still not widely validated because very few groups have published their experience, and we're one of them. But you know, with your support, with seminars such as this one, and again, I want to commend the organizers and Hanh and Andrew and many others for putting together this rare cardiac disease symposium, which I think is extremely useful because this is a forum where we can really share ideas. We don't have all the answers yet, so this is really something where we all learn from each other. So on this, I want to thank you, and it's been a pleasure being with you today.
Thanks, Marc. That was fantastic. I'll start with a question and then pass over to Hanh and Jakub. So one of the things that worries me a bit about cardiac myosin inhibitors is the de-skilling of surgeons. Do you think we're going to go back to a situation where we just have 1 or 2 centers per country? Do you think that's more realistic than expecting to have an expert myectomy surgeon in every teaching hospital who's perhaps only doing 2 or 3 a year?
I agree. I think your point's well taken. This is, fortunately, it's not an urgent lesion, right? So patients can travel. We probably, more than half of our patients come from outside of Ottawa. So, but I think your point's very well taken. You need a certain volume to really get on a certain level of comfort with those operations. Again, not that you're, you know, knock on wood, the patient's going to experience mortality or morbidity from the operation. But this is really an operation where you can do minimally anything, and the patient's just going to be back to baseline, right? That has to be avoided. And I think we've all seen those patients, and I saw them early in my experience, and I was, you know, the culprit for some of them, and you learn from them. And what's important is always to understand the disease. Every single patient is different, and I think we all acknowledge that this is a disease. It's a form of distortion of the heart. It's a heart that just didn't configure itself in the right way, and I think a multidisciplinary approach to trying to understand what's best for a given patient on an individual case-by-case basis is paramount.
Thank you. Hanh, back to you.
I do have a comment. Thank you, Marc, for you know, allowing us to dive into the world of surgery and see how it's being done. I just want to make the comment that it is the surgery with one of the surgeries with the lowest risk among all cardiac surgeries if done well in a high volume center. So I find that it is important to counsel patients well when we talk to them, because if we say, well, you have the opportunity of having open heart surgery or taking a pill, that's kind of an easy solution. But you know, educating them about the fact that it is a lower risk surgery, that it's a once and done, those things come into account too.
Great point. Great point.
Okay, we've got 2 minutes left. Let's have a out of left field question for my cardiology friends. So Hanh and perhaps Jakub will be aware that when in Ottawa during COVID, when we couldn't treadmill exercise people to look for gradients, I became a big fan of using dobutamine, which is a highly controversial thing to do. And is perhaps not generally accepted by the community at large. But you know, part of my argument is that if they can do it in the operating room, we can do it in the consult setting. But I'd be curious to know what you think, whether you think there is any role for any level of dobutamine testing for revealing gradients in patients for whom the echo windows are poor, or you're struggling, or you just need another look.
If I can answer, you know what, I've actually found a lot of found very useful to squat patients now that we can see them in our you know, and we've had you know, I can say 3 patients now that we've uncovered provocable LVOT gradient that was not found on the stress echo, that we squatted, we heard a loud murmur, we squatted them in the lab, and then we were finally able to put their symptoms and their gradients together. So I have some, you know, I think that for me that has worked well. So that's what we've been doing for the, yeah.
That's a very diplomatic response. Thank you, Hanh.
But for the dobutamine, you know, I have not had experience with that, but it is a good study. It is a good study to, you know, low dose dobutamine, what happens physiologically and what happens with patients with provocable LVOT gradient.
Yeah, I think the key is probably low dose. I've now tended to move away from anything I see above 20 mics per kilo. But many of these patients were getting clear obstruction at 10 mics per kilo, which doesn't happen in normal people, in my opinion.
I mean, I was thinking, why not just change the boat and isoprel them? But we don't have a standard isoprel echo. But, you know, if you don't have the afterload reduction and you just have the beta agonism, but we don't have any protocols, we don't have safety margins on that one, but it was just a different approach to pharmacological.
Yeah, I mean, I think that'd be a reasonable question entirely. Anyway, are we out of time?
Right on time.
Okay.
So thank you, everyone. Thank you to all our speakers. Thank you, Andrew. I hope you have a great rest of your afternoon.